Hello, everyone. Welcome to our NeoFOCUS bi-monthly webinars. We are very pleased today to have special guests from Dublin Rotunda Hospital. We have our guest speaker today, Dr. Rachel Mulally, who is going to talk to us today about the impact of early targeted early hemodynamic screening program. Dr. Mulally is a PhD candidate based in the Rotunda, where she's also a local consultant neonatologist. Her main interest is using neonatologists to perform echocardiography to improve outcome for extreme preterm infants. So I will open the floor for you, Rachel.
Thank you very much, Mahmood, and thank you for this great opportunity to present for you today. I'll just try to share my slides. That's great. Now, I do have to apologize because I've had a really bad flu for the last week. So hopefully my voice won't be too croaky during this. So I'd like to present the impact of a risk-based PDA treatment program for you today. And these are the main results from my PhD. My slides are not advancing. Apologies. There we go. The patent ductus arteriosus, as we know, has both pulmonary overcirculation and systemic hypoperfusion effects. And these manifest as prolonged ventilation, pulmonary hemorrhage, chronic lung disease, brain injury, poor growth, acute renal injury, and myocardial ischemia. However, a cause and effect relationship has not definitively been proven. In 2015, Afif and his research team devised a patent ductus arteriosus severity score, which predicts chronic lung disease or death before discharge. The score, it comprises 5 parameters: clinical and echocardiographic, so gestational age, PDA diameter, left ventricular output, PDA maximum velocity, and also tissue Doppler measurement at the left ventricle. So when all these parameters are put into the Excel spreadsheet, it gives us a nice calculation of the PDA severity score. So the score is based around the number 5. So anything less than 5 is deemed low risk, and therefore these babies would not be amenable for PDA treatment. If the score is greater than or equal to 5, they're deemed high risk and so would be amenable for PDA treatment. And I should say as well that this score is validated for babies less than 29 weeks gestational age. So as we know, hemodynamic significance of a PDA is very hard to properly categorize, and it's not just one thing that equals hemodynamic significance, but rather multiple different things that are amalgamating together in order to lead to hemodynamic significance. But this score can determine whether or not a PDA may become hemodynamically significant at a very early point in time, before it in fact reaches hemodynamic significance. So the group went on then to publish a pilot randomized controlled trial of early targeted PDA treatment using this risk-based severity score. And then they also performed a post hoc analysis of the results. And basically what was found in this post hoc analysis was that babies who successfully closed their PDA following PDA treatment with ibuprofen had better outcomes than those that did not close their PDA. And so our approach to PDA management in the Rotunda was devised from the results of this PDA RCT. And for the purpose of the results I'm about to present, we included babies less than 29 weeks gestation from July 2020 to March 2024. So this is important. This is the early targeted treatment epoch. We performed echocardiograms in our unit in any babies born less than 29 weeks in the first 24 to 48 hours of life. And then we performed the PDA severity score assessment using this echocardiogram. So this was done early, and that's very important, between 24 to 48 hours of life. So if the babies scored less than 5, they were deemed low risk. And so we observed these babies, they weren't treated, and we re-echoed them at day 14 just to reinterrogate the PDA, whether it's closed or not spontaneously. They then got a repeat echo at 36 weeks corrected, and primary outcomes were assessed at this point, which was mainly respiratory morbidity. Babies who scored greater than or equal to 5 were deemed high risk, and they received ibuprofen or paracetamol. So ibuprofen was their first line preference, and then paracetamol reserved for any babies who had a contraindication to ibuprofen. They received 3 days of treatment and were echoed after the 3 days of treatment. If the PDA remained open, they received a further course of treatment. We always checked echocardiographically whether or not a baby had closed their PDA after treatment. If the baby was still ventilated by day 14 and the PDA was still open, a device closure was considered at this point. And again, all babies are assessed at 36 weeks corrected, and their primary outcome of respiratory morbidity was also collected at this point. Another important point to note is that high-risk infants were divided into groups as per their PDA status post-treatment. So treatment failure, if they received treatment and didn't close their duct, or treatment success, where they closed their duct successfully following treatment. And comparison of these babies was performed with a historical cohort of neonates who had the PDA severity score retrospectively applied, but who were not treated as per the score at the time. And this is the reference epoch. So our first aim was to evaluate clinical outcomes of high-risk infants from the early targeted treatment epoch and the reference epoch. And we hypothesized that high-risk infants from the early targeted treatment epoch have improved clinical outcomes compared to the reference epoch due to introduction of a PDA risk score to guide treatment, and also that high-risk treatment success infants, so babies who have closed their duct after treatment, have better clinical outcomes compared to high-risk treatment failure infants, babies who have been treated but failed to close their duct, and also the high-risk infants from the reference epoch. Excuse me. Our second aim is to look at the low-risk babies. So we wanted to compare outcomes of the low-risk babies from the early targeted treatment epoch and the reference epoch. And we hypothesized that low-risk infants from the early targeted treatment epoch have similar clinical outcomes to low-risk infants from the reference epoch, indicating that no or minimal intervention is equally effective, and also that the PDA severity score can accurately identify low-risk infants destined to close their PDA spontaneously. So here are the results. We had 231 infants born less than 29 weeks gestation that were eligible for inclusion, but 47 were excluded, 27 because there was no screening performed, and 20 because they had initial pulmonary hypertension, which left us with 74 low-risk babies after the score was applied, and 110 high-risk babies after the score was applied. And then we also had our reference cohort here, which was divided into 51 low-risk babies and 84 high-risk babies. Of the high-risk babies from the early targeted treatment epoch, these were finally divided into 58 that responded to treatment and 52 that failed treatment. So our high-risk babies from the early targeted treatment era were compared to high-risk babies from the reference epoch, and our low-risk babies from the early targeted treatment epoch were compared to low-risk babies from our reference epoch. So just to start with the clinical characteristics divided by epoch for our high-risk babies. So just highlighting some of the significant differences. Babies born in the early targeted treatment epoch, they were slightly younger gestation, slightly smaller as well, had a lower first pH after delivery, more antenatal steroids, and more chorioamnionitis. And because of this, we performed linear and logistic regression analysis to adjust for gestation, first pH after delivery, and antenatal steroids, and chorioamnionitis for the remainder of these results. These are the primary outcomes, again divided by epoch in the survivors only. So if you look at ventilation days, there was no significant difference between epochs, but in terms of oxygen days, there were 54 oxygen days in infants in the early targeted treatment epoch, significantly less than the 65 in the infants from the reference epoch. And similarly, there was less chronic lung disease, 69% in the early targeted treatment epoch compared to 76% in the reference epoch. So less oxygen days and less chronic lung disease in the early targeted treatment epoch. Excuse me. So looking at secondary outcomes then by epoch. So there were significantly less severe IVH, that's grade 3 and 4, in the early targeted treatment epoch compared to the reference epoch, and also less retinopathy of prematurity requiring treatment in the early targeted treatment epoch compared to the reference epoch. Otherwise, outcomes are similar between groups. Now, for the next few slides, we divide those infants from the early targeted treatment epoch into those who had treatment failure and treatment success. Sorry, I knew this was going to happen at some point. Take a minute. So, sorry, this is terrible, sorry. Right, babies from the early targeted treatment epoch when they're split down. So infants were of smaller gestation, they're also of a smaller birth weight. PDA severity score was significantly higher in the treatment failure group. And of course, as well, exposure to PDA measured in days was higher in the treatment failure group. If you look at the treatment success group, these are the babies who closed their duct successfully following treatment. So you can see that the median days of PDA exposure was only 5. And then if you look at the high-risk infants from the reference cohort, the median PDA exposure was 21 days. So that was also significantly lower than the treatment failure group. Other differeces were in antenatal steroids. So there is more in infants in the early targeted treatment epoch. Chorioamnionitis was more common in infants in the treatment failure group, and preeclampsia was also less common in infants in the treatment failure group. So, when we look at PDA treatment itself, you can see that babies from the reference epoch, about 50% of them received any PDA treatment. But when you look at when the first PDA treatment was actually commenced, this was not early. It was day 9 compared to early in the treatment failure and treatment success group at day 2. And then when you look at the primary outcome as well in survivors, when we split them into treatment failure and treatment success, ventilation days, significantly less in the treatment success group compared to the treatment failure group. And oxygen days as well, 45 in the treatment success group, which was significantly less than the treatment failure group and the reference epoch. And similarly, chronic lung disease, 59% in the treatment success group, which was significantly less than the 81% in the treatment failure group and the 76% in the reference epoch. In terms of secondary outcomes, time to discharge was significantly higher in the treatment failure group compared to the other two groups, and also retinopathy of prematurity needing treatment was significantly higher in the treatment failure group as well, compared to the treatment success group. Outcomes were similar. When we look at other secondary outcomes, there was no significant difference here in terms of severe IVH or PVL, but there was a trend towards improvement in the treatment success group. And then I also just want to draw your attention to the death before discharge. So there was no significant difference between groups. There was a slight trend towards higher death before discharge in the treatment failure group. We did look into this further. So we performed logistic regression, and we saw that there was a significant association between higher gestational age and mortality. No association between completed course of antenatal steroids or chorioamnionitis, or indeed successful PDA closure by day 6 and mortality. And we saw that exposure to ibuprofen and exposure to paracetamol was associated with a decrease in mortality, which was quite interesting. And then we looked at associations of chronic lung disease, and there is no longer an association between gestational age and chronic lung disease. Again, still no association between antenatal steroids or chorioamnionitis. There was an association between less chronic lung disease and successful PDA closure by day 6. And there was an association between, there was no association between exposure to ibuprofen and chronic lung disease. But interestingly, there was an association between exposure to paracetamol and actually 4.5 fold increase in the risk of developing chronic lung disease. Finally, to move on to our low-risk infants now. So looking at the clinical characteristics between eras, they were pretty similar between groups, slightly smaller birth weight in the early targeted treatment era, lower first pH, lower APGARs, more antenatal steroids, and more preeclampsia. And then looking at PDA treatment, so you can see that both groups received very low levels of PDA treatment. And when we looked at outcomes, they were pretty similar between eras again. So slight difference in ventilation days, time to full feeds, no death before discharge in either group, and no significant difference in chronic lung disease between groups either. So to conclude, infants, high-risk infants, when we looked at their outcomes by epoch, we saw that infants from the early targeted treatment epoch had fewer oxygen days, less chronic lung disease, lower IVH, lower retinopathy of prematurity, and no significant mortality difference between epochs. And when we divided the high-risk infants from the early targeted treatment epoch into treatment success versus treatment failure, we saw that successful PDA closure led to fewer days of mechanical ventilation, oxygen use, chronic lung disease, shorter discharge time, and lower retinopathy of prematurity requiring treatment, with again no mortality difference between groups. Ibuprofen and paracetamol exposure was associated with a lower mortality risk, and paracetamol exposure did have this association with an increased risk of chronic lung disease. Successful PDA closure by day 6 reduced chronic lung disease rate. And in terms of low-risk infants, both reference epoch and early targeted treatment era infants had low treatment rates, and the PDA severity score successfully identified infants who did not require early treatment. And we saw that no intervention was effective for low-risk infants, which did minimize unnecessary intervention and exposure to pharmacological or potential pharmacological side effects. So overall, we've seen that implementation of a risk-based early targeted treatment approach to the PDA significantly improves respiratory outcomes. Alternative treatment strategies for high-risk infants who are non-responders to early targeted medical therapy should be explored to improve outcomes for infants who fail their medical treatment. And further research probably should include the use of higher doses of ibuprofen, alternative routes of administration, dual medical therapy, or early definitive bedside device closure, perhaps. But it is important, however, to note that we think the use of a proven stratification scoring system in any such studies will be key to generating clinically useful information and to improve patient outcomes. So thank you to everyone in the Rotunda Hemodynamics research team, and I sincerely apologize for the coughing fit in the middle of the presentation. Thanks for listening.
Thank you for this fantastic talk, Rachel. I will hand over to my colleague Anne-Marie Huken, who is a neonatologist in the Royal Hospital for Children in Glasgow, just to introduce our guest panelists. Over to you, Anne-Marie.
Okay, thank you so much, Rachel. That was absolutely wonderful. Just while people are getting their thoughts together after that excellent talk and putting questions into the Q&A box, I just want to introduce our wonderful panelists. We're continuing in a theme of expertise from the Rotunda in Dublin. First of all, I've got Dr. Aisling Smith. So Aisling's a recently appointed consultant neonatologist at the Rotunda Hospital in Dublin. She has expertise in neonatal hemodynamics, and undertook her PhD studies looking at observational work, looking at myocardial function and pulmonary hypertension in cohorts of term babies affected by Down syndrome, or those who are infants of mothers of gestational diabetes, and infants conceived with assisted reproduction techniques. Many of you will be aware of Aisling's absolutely excellent work, important observations and wonderful presentations on pulmonary hypertension in infants born with Down syndrome. Aisling's now continuing her research focus, looking at these term cohorts, but is also involved in research looking at the preterm population, low flow states and PDA. Then continuing on the theme of the Rotunda and Dublin, we're delighted to have Professor Afif El-Koufash with us. Afif is a consultant neonatologist at the Rotunda Hospital and also a professor of paediatrics at the Royal College of Surgeons in Ireland. Afif trained in Dublin and then in Toronto, and then worked as a neonatologist in Toronto, and also during his studies completed a year's fellowship in paediatric cardiology. I think Professor Afif could probably be referred to as a polymath because of his significant additional interests outside the world of just neonatal echocardiography and hemodynamics. His interest and accomplishment extend to his involvement and expertise in lactation, and whereas he's a lactation consultant, he's also an accomplished graphic artist and is known widely for his popular podcast, The Baby Tribe. However, his primary research work and interest is in assessment of cardiac function in term and preterm babies. He's extensively published, holds numerous grant awards and research awards, and is a recognised leader devising training programmes and standards for neonatal echocardiography around the world. So it's delightful to have you both, and I look forward to you answering some questions along with Rachel on her excellent presentation. Just while Mahmood gets together the questions, I was just going to ask the panel. I think we've now seen a number of QI studies and postdoc analysis of RCT studies where we've found that duct exposure with or without ventilation is related to the evolution of chronic lung disease, and that those babies who are responsive to duct treatment and achieve duct closure seem to do better. And given all the massive challenges of RCTs and the difficulties of excluding clinician bias and ensuring that we get the correctly recruited babies, do you think the days of RCTs for PDA are over, or is it about developing better RCTs? Is
this for me or Rachel?
I'd be delighted to hear from Rachel, but
oh, sorry, yeah, go ahead.
To you. I think over to you, Afif.
Yeah, we'll give it to Afif, give my voice the rest.
Yeah, thanks, Anne, and thank you for the lovely introduction as well. It's interesting that you say that because I was actually in Nijmegen in the Netherlands yesterday and the day before, and on Wednesday I was an external examiner for Tim Hunchfield's thesis, and Tim, as you probably know, has published the Benedictus trial under the supervision of Willem de Buda, and I was there examining his the thesis that came out of this trial, and we had a very big discussion in a symposium that was done before the thesis examination, where I sort of gave my perspective on where RCTs are in terms of PDA trials at the moment. And I think that we should stop. In fact, I would go further and I would say that it is actually unethical to continue doing PDA RCTs the way we are doing them right now. And we should really drastically change our approach in I guess 2 or 3 aspects of how we conduct these trials. The first one is that we really need to improve our patient selection, because I guess what the studies have taught us, especially the most recent studies, is that if you unnecessarily expose babies to these NSAID drugs, which have a lot of side effects, without the benefit outweighing the harm, that you are going to overall harm them. And we see that with the increased incidence of chronic lung disease in the Benedictus and a trend towards increased mortality in these babies. So babies that don't respond to medication basically have all the side effects of the medication without the benefit. And I think we need to keep that in mind. And also, I am convinced, what I learned about the Benedictus trial, for example, that out of 1,600 potential babies that could have been enrolled, they were only managed to enroll 250. And when I pressed the people on whether they felt that the babies that were enrolled are similar to the babies that weren't, I wasn't given a clear answer. And I suspect that a lot of the babies that were not enrolled were the babies that should have been in the trial. Clinician bias would have probably prevented these babies from being enrolled because they were the sicker population, whereas we actually need to be examining those babies. So I'm not surprised that the rate of chronic lung disease in the Ductus trial was high, because I suspect that the majority of these babies did not need treatment. And what I guess demonstrates this, and nobody thinks about this, is that in the placebo arm, these babies were actually fine. In fact, a lot of them spontaneously closed their ducts. And you don't need these babies in trials. You need babies that are destined to keep their duct open so that you can try and modify their history. So patient selection is huge. The second aspect, obviously, is that we need to develop better ways of administering these medications to ensure a higher rate of successful closure. What Rachel demonstrated there is that only 50% of the babies actually responded. But what she didn't show you was that, in the 23, 24, 25 weekers, and the 23-week babies that were in, only 27% actually responded to treatment, and only half of the 24, 25, 26 responded to treatment. So these are the babies that we need to improve our closure rates that are high risk. And then we need to try and prevent open label treatment, significantly. And that's something that a lot of studies have had a challenge with the notable exception of the Benedictus. So what the Benedictus showed us really is that it is possible to not intervene, but I suspect the fact that they had such a high rate of or a low rate or almost a negligible rate of open label intervention is the fact that these babies were well and the physicians didn't feel that they needed to actually intervene. And I would, I guess, propose that if the right patients were enrolled in the trial, that people would feel very, very nervous about not intervening in these kids.
Thanks, Afif. I think it's a real observation and is really important considering, and is something that also came out, though perhaps not quite as clearly as you describe it, did come out from the PDA Tolerate trial, where there was the lack of equipoise.
Yes, and in fact, the babies that weren't enrolled in the trial and were treated had better outcomes,
correct,
which goes to show you that, and you see what worries me and is that in the Netherlands now, because of the Benedictus, they have now put a national policy of non-intervention for PDAs, which makes me extremely nervous. That based on 200 babies that were relatively well, we are now basically in a whole country, completely dictating how ducts should be managed, which makes me very nervous.
Indeed, I hadn't appreciated that. It's very interesting. And I think what your study and perhaps other study shows the benefits of actually collecting data on your control arm, and even in those infants who were screened but not recruited, are going to be very important for any future studies.
Yeah, and I think Rachel really needs to be congratulated, because I don't think that there is another data set out there that is like this, showing you in detail what happens to every single risk category, what happens to high risk responders versus non-responders, what happens to the babies that we leave alone. And what she hasn't shown you is that we have a lot of physiological echo and clinical data basically corresponding with the outcomes as well. So it makes a very, I guess, compelling argument without the RCT label, I guess, that some babies will benefit from early closure.
Fantastic, thank you. I'm going to bring in a question from Jay Banerjee, which I saw. Here we go. It's indeed congratulate you, as I think we all would, Rachel, on your fantastic presentation and your fantastic work that you've brought together here. Jay says, we're intrigued to know, how do you hypothesize the increased risk of chronic lung disease in infants exposed to paracetamol? And was there a difference between low risk and high risk babies in terms of outcomes if they were exposed to paracetamol?
Yeah, thanks. That's a very good question. I suppose the short answer is we don't know why that happened, why we see that association, but it is known. There's very few animal studies done already, and some studies are showing that the paracetamol can affect lungs before they even affect liver enzymes. So perhaps preterm babies are affected via the respiratory system in terms of toxicity from paracetamol before it would even be evident in, say, liver function tests being abnormal. We don't really know, and it could, again, perhaps it's something to do with the babies who are exposed are having side effects from these medications if they're not benefiting, perhaps.
Yeah, that's quite interesting, and I suppose I will just follow on the same kind of note and line. Would that make you nervous then to start paracetamol for treating PDA in the future, or because we don't have enough data, or maybe select wisely those babies who to start? What do you think, Afif?
So, I mean, we know actually, I'm nervous about using paracetamol, and we'll reserve the use of paracetamol in babies that have clear contraindications to ibuprofen, that we really want to achieve ductal closure in. So we don't use that as first line. And I think that should be the approach, because I don't think that we have enough safety data on paracetamol. And what we know from a lot of animal studies is that it does prevent, it is anti-angiogenic. Prostaglandins do a lot of good things in the lungs, and what we forget, I guess, is when we give NSAIDs and when we give paracetamol, that we mess up prostaglandin production all over the body, right? So it's your 2,000-pound bomb that just trying to target one thing, but actually has a huge loads of collateral damage. Whereas what we need really is a precise strike, and we don't have that capability yet in terms of medication. So until then, we just need to use it very judiciously. When there are clear contraindications to ibuprofen, where we have a much, I guess, much better knowledge of its safety profile. I have no doubt that the use of paracetamol is harmful for the lungs in babies. We see that in animal studies. It is anti-angiogenic. It does increase pulmonary vascular resistance, and I'm sure it has some parenchymal effects as well. And that association is clear. I think partly whether we avoided mortality in some of these babies that ended up presenting as chronic lung disease is another thing to consider. But I would be nervous about people that have just dropped ibuprofen and are using paracetamol, without, I guess, keeping an eye. And this, I guess, is another example of why you should always keep very close eye on what you're doing. And we've learned something, I guess, new that's quite stark, in terms of the effects of paracetamol on what can potentially happen to the lungs. And again, it just makes us, I guess, take a step back and think before we start paracetamol on a baby.
Okay, thanks, Afif. I've got a question for you, Aisling. They're just talking about the routine scanning or early scanning for PDA, which we usually do for like cranial scans as well. Do you think that's the way forward for those preterm babies?
Yeah, absolutely. I mean, our group in Dublin, we're building up our hemodynamic service, and Afif has been leading on that for years. And there is a core group of us that are developing that service. So in our extreme preterm babies, we really aim to do a hemodynamic assessment in the first 24 to 36 hours or earlier if required. But that just depends on service availability. We're not a 24-hour service or even a 5-day-a-week service, but that is what we strive for. At which point we are assessing the whole hemodynamics, pulmonary vascular pressures, the myocardial function, and obviously a structural assessment as well. And if the baby has a PDA, then we are applying the risk score to actively manage the PDA in the high risk babies with scores over 5. But obviously, and Rachel has another fantastic piece of work that's going to come out. A lot of these babies, and I mean, this is work that's also that Rachel is going to publish, but has been also demonstrated by groups like the Iowa group. A lot of these small preterm babies have delayed transitioning, and a lot of them can have pulmonary hypertension that clinically may not be overtly evident, but a substantial proportion of them could have bidirectional PDAs, in which case, obviously, we don't elect to treat those. And sometimes a lot of those babies may benefit from nitric or some milrinone, or they actually have subclinical biventricular dysfunction or even LV dysfunction. So I think what we're seeing is that in the extreme preterm population, there is a variety of phenotypes that might be present from a hemodynamic standpoint, and having that kind of early hemodynamic management is extremely beneficial, not just for selecting out your high-risk PDA infants, but also really categorizing what physiology might be happening and how best to support the infant. Now, obviously, the group that's really spearheading a lot of this is Patrick McNamara's Iowa group, and they are coming out with their papers that are really showing huge impacts, positive impacts on clinical management with dedicated hemodynamic services. You know, they're reducing IVH and very low neck rates, and those really positive outcomes. However, that's obviously a resource that they are lucky enough to have access to. So I think what we see clinically here is that a lot of the times when you scan these small babies, you can pick up a lot of other information that may not have been clinically overtly evident. So yes, to answer your question, we really try our best to scan our extremely preterm population, the babies less than 29 weeks, in the first 24 to 36 hours, to guide not only the PDA management, but the overall hemodynamic management of the babies.
Grand, thank you.
I want to go back to some of the questions that are coming in through the Q&A. Although just before, I'm just going to ask Rachel one quick question. Those babies that you scanned at pulmonary hypertension early on, did you follow them up, and then if they developed a significant PDA based on your scoring, they then go on and have treatment?
Yeah, that's a good question. Some of them did, is the answer. So we would have followed them. Maybe it kind of depended on like echocardiographer availability, like every 24 hours until the shunt became predominantly left, right. And then some of them would have been scored at that point and treated. But for the purpose of the analysis, they weren't included in those high-risk babies.
Okay, thank you. And to go back to the questions, just along with the questions you've been asked about paracetamol and the adverse effects that you have been able to demonstrate in some of your babies, there are questions about whether or not you measured paracetamol levels or what dosing regimes you were using.
So
Yeah,
we tried for a while. Sorry. It kind of predates Rachel's time. We did really try to do that, but it was just technically a very challenging thing to do. So we were not able to actually do that. Interestingly, I'll tell you a quick anecdote on the use of paracetamol in this babies. We had a baby that was being treated for paracetamol, and at the same time got a full metabolic workup for a very, I guess, wishy-washy indication. And I got a panicked call from the lab saying, this baby's liver, there's something really, really wrong with this baby's liver, and you need to do something about it immediately. All the metabolic workup tests are off the scale. And it looks like there's a severe glutathione depletion picture in this baby, and I'm really, really worried. And when I told them that the baby was receiving paracetamol, they said, well, that's what's going to do it. You see, I think the problem is that LFTs are a very crude way of assessing liver dysfunction. They only go off once a significant number of your hepatocytes have taken a hit. So I'm never reassured by normal LFTs when we give a baby a paracetamol, because I think we're causing a lot of hepatotoxicity that does recover, but we just don't see it. And I guess when I heard that that was a wake-up call for us to do it. And then we were actively trying to do not just paracetamol levels, but kind of an assessment of glutathione depletion. And we could just never get on top of it. So the quick answer is no, we're not doing them, but we should.
Yeah, it's interesting. I noticed that Liam from Bristol has said that they're doing paracetamol levels.
Yeah.
We also have continued to do them in Glasgow so recently, following the tolerate protocol. I'm not sure about others, but I'd be interested to know if you found a difference. You probably told us, Rachel, you're very comprehensive, but I didn't take in a difference between the efficacy of paracetamol and brufen when closing the duct. We haven't felt that paracetamol's got great efficacy here. But we've also noticed that using that monograph, we've never had high paracetamol levels, which is slightly reassuring in terms of toxicity, but equally, I'm not sure that we're getting efficacy.
Yeah.
No, you're right. I didn't include that. We didn't look at the breakdown actually between ibuprofen or paracetamol and whether the duct closed or not. That's a good point.
Okay, we look forward to hearing.
Yeah, no, we have that information, and it's somewhat difficult in that very few of our babies got paracetamol as first line, and we usually give it after failure of ibuprofen treatment, or if there's a lot of contraindications, and these are usually in the sicker group and they don't respond as well. So our rates of closure aren't great, and we tried to tease it out, but maybe part of the association between paracetamol and chronic lung disease is the fact that it's given to babies where ductal closure isn't achieved. We did try and adjust for duration of exposure to the shunt as well, and it came out as an independent association, regardless of whether there was successful ductal treatment or not. So, yeah, I mean, when we looked at it before, it appeared that the efficacy, if you start it early, would be similar to ibuprofen. But again, we're not using it as first line.
That's very interesting. Thank you.
I've got a question while we're just waiting for more questions to come in the Q&A box. So Afif, you had this interesting paper in 2018 about the relationship between diastolic dysfunction and early respiratory morbidities. And also, I know Cordoval did something similar in 2023 about also chronic lung disease associated with diastolic dysfunction. Your score is already, you started the work about this in 2015 and validated the score with 5 parameters. Have you looked at any diastolic dysfunction components, particularly E prime ratio, for example, or have you thought about LA volume or LA strain?
So we do have a measure of diastolic dysfunction in our score. So the LA, LVA prime. When we looked at the various measures of diastolic dysfunction, this one came out as the most predicting one. So there was no point in including several measures of diastolic dysfunction. We just picked the best one. So we looked at the conventional measures. We looked at EA ratio. We looked at EE ratio as well. So we looked at a lot of diastolic function measures, and this one came out on top. In terms of LA strain, we have just finished gathering the data to just learn about what LA strain does in various hemodynamic physiological situations. So in big stretched left atria, because we have that data, right? We have babies that didn't close their duct and were subjected to a high preload, a high volume shunt. So we're just analyzing that data. And again, we had this discussion. If you start swapping out components of the score, then you have to go back to the very start, right? And go through the whole scoring process from the outset. I guess what people don't realize is that our score is the only validated score of PDA significance out there, and it has gone through a thorough validation, like every new measurement should, right? So we derived these variables from a treatment naive population. We looked at hundreds of variables and whittled that down to those most predictive 5. We then validated it in a different cohort in a different country, and it gave us the same results. We then validated it in an RCT setting, and we're now further validating it in a practical clinical application setting. All of the other scores out there have just been arbitrarily set up without thought put through behind them, and they're being implemented in the clinical service without the robustness of what we have done. And people often ask me, will you swap this into this? And people unfortunately say it flippantly, without, I guess, realizing the science behind developing a score or a scale such as this. If you want to substitute it with something else, then you have to go back to the very start, apply it in a naive population, see if it tells you what it's meant to tell you, see if it's predictive enough, and then, take the steps that we have taken. So I'm not prepared to go through that process again. If somebody else wants to do that with LA strain, go right ahead. But I don't think LA strain is going to give you any more predictability than what we have already.
That's great. Thank you, Afif.
Thank you. There's one question I think we missed from the panel, which I think is an important one, and that's from Annie. Annie's asked, do you undertake a separate subgroup analysis for babies less than 25 weeks gestation? They're obviously the babies at the biggest risk of morbidity and adverse outcomes. And I suppose that's to Rachel in the first instance.
Thanks. Yeah. So we didn't, because our division was high risk versus low risk. But we do have more details on whether these babies manage to close their ducts or not. by gestation, as Afif mentioned, and some other risk factors as well for treatment failure. But no, we didn't overall just look at babies by gestation.
Okay, that's great, thank you.
Yeah.
On the
Yeah.
Mehmet, do you want to come in?
I think Aisling wants to comment.
I'll just add that, like, it just because just to make it easier for people who are listening to understand, the chances of like a 28-weeker, you know, a 28-weeker is not going to be a high risk infant. So actually, the score inherently is essentially what that person is asking for in a subgroup analysis. The score itself is doing that, because the babies who are going to score high risk are going to be the smaller, lower gestational age babies who Rachel is describing inherently as a high risk cohort. Because a baby who's essentially close to a kilo, or 27.5 or 28, is going to be a low risk infant inherently. So it's kind of a moot question. The score itself has done that subgroup analysis, if that makes sense.
Yeah, and just to build on, yeah, that's a great point, Aisling. Most of our babies are under 27 weeks, so up to 26 and 6. So in the high risk category, if you look at the average gestations, it's like the low 25s. So we've kind of selected out, these babies in the score, and most of our low risk babies are over those gestations.
That's perfect. Thank you. There is another question about the use of the score for just not only at day 2, but later on, like day 14. Is that still valid to use?
Nope. It's simple. So again, what I guess a lot of people don't understand about the score or scores like this, that it is only applicable in how you devised it, right? So this score only works when you apply it between 36 and 48 hours with a stretched 24 to 48 hours. It is not validated, nor was it developed at beyond that. So we looked at a few time points when we were originally developing the score. We looked at day 1. It wasn't able to discern between babies that went on to close their ducts versus babies that kept their duct open. And at day 7, you missed the boat. You've left the baby exposed to the duct for 7 days. There's no point in applying the score then. But the score wasn't developed for that time point. And we looked at that time point, and it wasn't really very predictive at that stage. So if you are using our score, and I've seen a lot of people trying to use it to decide whether to send the baby for a ligation or not at 3 or 4 weeks of age. And that really, it's not developed for that. And it's only valid when you apply it between 24 and 48 hours, because that's how we developed it.
Thanks, Sophie.
Thank you. I think I just want to say that everyone who's submitted questions, Rachel, have just been commenting on what fantastic work it is, how much they've enjoyed your presentation, and how really exciting it is to see this data. So tremendous work, and thank you for sharing it. I wanted to come back to maybe a question to the panel, just considering that such a number of babies didn't respond to treatment. What novel therapies do you think we might be thinking about, or do you think within the UK and Ireland we might be having to think more actively about following the kind of North American lead of trials of interventional closure?
So we're currently doing an RCT of randomizing our high-risk babies to ibuprofen alone versus ibuprofen and paracetamol at the same time. It's the ACE duct study. It's a North American study mainly done in Canada and our center as well, hopefully expanding to more centers to see if the double exposure is going to help, hopefully without significant side effects, but we don't know that yet. The other thing that I think needs to be explored is a slower 24-hour infusion of our NSAIDs. There's been small-scale studies showing that this steady state exposure gives you a really high rate of ductal closure, especially in babies less than 26 weeks gestation. And a lot of centers that are using the oral formulation report really high closure rates. And I think the difference between a quick infusion of the medication versus the 24-hour exposure and the oral exposure is that you get a much longer duration of exposure to the medication rather than the quick spike you get with the push and then down again. So, we don't even have to start looking at different drugs. We need to see how can we actually administer the drugs that we have in a better way. And I think oral is good, but I think our unit is still a little bit too chicken to actually use it, even though a lot of places are using it with no increase in the risk of neck. I'd love to explore the 24-hour infusion, but again, our pharmacist won't let me. Um, so we still have a lot to do. And also there's a lot of talk about randomizing babies into early device closure.
Yeah.
So that's the cleanest way, if you like. There's no exposure to any side effects, medications. Of course, you have the side effects of the actual procedure itself. But I guess people are still a bit nervous of doing that, over the first week of age or throughout the first week of age. So, there's still a lot to explore and learn.
Thanks, Afif. I think there is one more interesting question about is there a buy-in from cardiologists to do these echoes, or is the hope is that the PECs or neonatologists with expertise in echo would be doing that? I know Aisling and Anne-Marie already working on a European group for that. So Aisling, do you like to answer that question?
Yes, well, in our department, we have an excellent working relationship with our pediatric cardiology colleagues. Our site is only maternity. It's maternity and neonatal. We're totally physically separate from the pediatric cardiology site. So we do have very strong clinical and academic links with our pediatric cardiology colleagues, but our service, our hemodynamic service is so large that they would have absolutely no interest in doing all the scans that we do. So both Afif and myself actually did pediatric cardiology, did training in pediatric cardiology for a period of time as well. And Rachel is actually going to do a clerkship with the pediatric cardiology department from January. So I think we have a very healthy and respectful view of our limitations. We are not cardiologists, we are neonatologists who perform echo. However, what's lovely is the pediatric cardiologists really see the benefits of very detailed hemodynamic assessments. And we have a fantastic working relationship with them. They know that we will call them if we have any kind of concern for a structural lesion, or if it's particularly complex physiology that we would like additional input from. But there's no way that they could in any way support or do the number of scans that we're doing. They just understand that if we are facing difficulty or complexity or any concern about a structural anomaly, or if we're getting to a phase where we need to request their input with regards to seeking a device closure, that's the trigger point that we will involve them actively in the care. And other than that, in the department, if there's structural anomalies antenatally detected, that automatically goes to the cardiologists and not, we are performing functional echocardiography. So I think in our department, it just has very kind of organically and respectfully evolved the working relationship with the pediatric cardiologists, and that needs to be maintained over time. Yeah, and just to build upon what Afif's last point was, I think in our department, it's the new frontier for us is how can we increase our closure rates? I think we all know that we have a very effective way of picking out the high-risk babies, but now the barrier is increasing the efficacy of the closure. And the device closure piece is fantastic, but the problem is that the high-risk ducts are going to be in the 23 weekers, and I'm not sure there's anyone in the world performing bedside device closures in 23 weekers. So there will be a cohort of infants who might be suitable for device closures early, but they're going to have to be the bigger, heavier babies. So then you're still going to be left with how can we medically optimize, whether that's oral administration, the 24-hour administration, etc. What pharmacology can we manipulate to increase the closure rates? So to us, that's the new frontier. We know what kids we need to treat, and the new frontier is how can we increase the closure rates? So that's where I think our department is at now.
Perfect, thank you.
I think that's all of our questions that have come in for now, and I must admit, and you've all answered them extremely well, and also answered many of my own questions, and I found it extremely informative and useful. And I very much look forward to hearing more from you, Rachel, as your publications start to come through. I think it's just over to Mahmood now. Can we have further questions?
I've just got a last question, unless anybody else would like just to put a last minute question. So in the subgroup analysis, I was interested to see the failure to treatment group has more criteria of chorioamnionitis and other issues. So if you scan a baby and you come across those red flags, if you like, would you still treat those babies? Or do you think of something different? I know that we don't have many options anyway. Afif?
So we actually did look, we haven't presented data yet, but we did look at predictors of ductal closure of response within the high risk group. And really there was nothing clinical with the exception of PET. If you have PET, you're going to close your duct if you're treated. And sometimes babies with PET, a lot of babies with PET were actually low risk because they didn't have a duct by the time we got to them. So PET closes your duct for whatever reason. In terms of chorioamnionitis, again, I don't think that we would shy away from treating a baby that is culture negative, but there was evidence of maternal chorioamnionitis because we're not seeing a signal of harm there. Really, the higher mortality, I think, is coming mainly from the fact that they are of a much lower gestation and the increase in chorioamnionitis overall in our cohort. We have a much sicker cohort now. Our demographics have changed to the worse. In our catchment area, we have a huge immigrant population now. And they usually come from disadvantaged backgrounds. We are the only maternity hospital in the country with a rising birth rate. Everywhere else, the birth rates are falling. And just to give you, I guess, put it in context, in Ireland 10 years ago, we had 70,000 deliveries. We're now down to 55, 10 years later, 55,000 deliveries. So our birth rate has significantly dropped. But the Rotunda Hospital is the only hospital with increased bookings year in, year out. So we're not seeing that kind of drop in trend, and our population is becoming sicker. I mean, our chorio rate went from 5% in 2015 to 25% now. That's a huge risk for mortality. And I guess despite that, we kept the mortality pretty similar between the two epochs. Whether you want to say that it's because of our approach to PDA treatment. Of course, it's not just that. We had a lot of important changes in what we have done. So it would be very disingenuous of me to just put it down to our PDA approach. But I think you have to look at it as a whole package. And yes, you can be concerned when you look at the the high risk population that failed treatment in isolation. But when you put it in context of a rising mortality throughout, and to see that the babies that responded to treatment, their mortality has remained, I guess, comparable to 2015, and it's only the babies where we failed treatment that the mortality is higher. And again, we've looked at this very closely, and I don't think it's the fact that they are being treated for the duct that raised their mortality. I think there's a lot of other factors that contribute to that, but it's something that we're going to keep looking at. So we're not going to stop examining the data. Now we're going to keep looking at it every 2 years to make sure that, the good trends continue.
That's perfect. Thank you so much. So I think we don't have any more questions. So I think I will just have to thank you, Rachel, for the fantastic talk. Thanks, Aisling, and thanks, Afi, for your time and the great question you answered. Thanks, Anne-Marie. Thanks, everyone, for joining, and we'll close the session now.
Thank you very much.
Thank you, everybody.
Thank you.
Appreciate it.
Thanks very much.